This is the final section, or part 3, of the movement dysfunction lectures, and the topic focus for this lecture is on reflexes and reactions. Primarily just have the one objective, and that is to differentiate abnormal reflexes and reactions. As you know, a reflex is a stereotyped muscle response to some sort of sensory stimulation. The stimulation is usually tactile or vestibular. Movement progresses from primitive reflex patterns to voluntary controlled movement. In a newborn and young infants, motor reflexes provide the first method of interaction with the environment, such as a reflexive grasp, and are essential to life, such as the suck-swallow reflexes. Because early reflexive movements serve functional needs, the newborn appears surprisingly competent. These reflex patterns subside as balance, postural reactions, and voluntary motor control emerge when the infant learns to roll, sit, creep, and stand, and walk. Reflex patterns subside as balance, postural reactions, and voluntary motor control emerges, such as when the infant learns to roll, sit, creep, stand, and walk. Human reflexes and reactions develop in a sequence and interact with each other. Therefore, it's difficult to attribute any one behavior to a specific reflex or reaction. Reflexes and reactions are being integrated and adapted as they develop. Classic theories, the reflex hierarchical theory of child development, placed great importance on a reflex substrate for the emergence of mature human behavior patterns. This means that in the normal child, the emergence of posture and movement control is dependent on the appearance and subsequent integration of reflexes. According to these theories, the appearance and disappearance of these reflexes reflect the increasing maturity of cortical structures that inhibit and integrate reflexes controlled by lower levels within the CNS into more functional postural and voluntary motor responses. However, more recent theories, such as the systems theory, ecological, and dynamic theory, have suggested postural control emerges from a complex interaction of musculoskeletal and neural systems, collectively referred to as the postural control system. The organization of elements within the postural control system is determined by both the task and the environment. With that being said, I think it's important for you to understand normal and abnormal reflexes and how it might play a part in the child's development or the progression of their development, but not get too hung up on using reflexes as far as your intervention. Years ago, neuromaturational theorists such as Bobath used reflex inhibiting postures and patterns as strategies for treatment and intervention. However, that evidence does not support the use of reflex inhibiting postures for treatment. Clinicians now used localized, limited inhibition of ineffective posture and movement synergies to redirect movements during the facilitation of function. Children who have abnormal development may have ineffective reflex responses, or they may have a very strong, pronounced reflex in response to the stimulus that persist over a longer period of time than necessary because the voluntary control of movement does not come in. Postural reactions, these are things like your righting reactions and protective reactions and equilibrium reactions. These usually develop between 4 to 6 months of age. Children tend to develop postural reflexes in a predictable sequence, such as prone and supine positions to quadruped to standing. Postural reflexes act primarily to align the head with the body, keep the head in an upright position, and maintain equilibrium. There are 3 major categories of postural reflexes: attitudinal, righting, and equilibrium and protective reflexes. Attitudinal reflexes appear within the first year and are designed to align the head with the body. For example, when the infant changes his head position, the position of his limbs automatically shift, as in the symmetrical tonic neck and asymmetrical tonic neck reflex. But attitudinal reflexes are suppressed early in infancy, but may reappear after injury or trauma to the brain. Righting reflexes are typically observed at about 3 months of age and persists to 6 months. When rotation is imposed on the body, the righting reflexes realign the segments of the body and bring the body into appropriate alignment. They are designed to align the head and gravity, the child's head upright, to realign the head vertically when the body is displaced, and are mediated respectively by the visual and vestibular systems. The third category, equilibrium protective reflexes, are present at about 6 months of age and persist throughout life to help the child remain upright. Equilibrium and protective reflexes are whole body responses to instability. Shoves or pushes to the body or tilting of surfaces on which the child is standing or sitting will elicit these responses. These reflexes help children protect the body from injury during loss of balance. If some instability occurs, they could lead to a fall. The child extends the appropriate set of limbs to protect the body. Children develop equilibrium reactions in supine and prone positions between 5 and 8 months of age and continue to develop equilibrium in more upright positions throughout early childhood. Occupational therapy practitioners evaluate reflexes and reactions as an indication of the child's neuromotor status, and the intervention emphasis is on improving postural stability and equilibrium to enhance the child's occupational performance. Thus, therapists help children improve balance and equilibrium reactions for play, mobility, feeding, dressing, self-care, and school functions. And I want to emphasize the importance of understanding reflexes and reactions, but not focusing your intervention on strategies to inhibit these reflexes, because we want to look at reflexes as how they support function. So when you have abnormal reflexes that are persistent, it's going to demonstrate problems with function. For example, if a child has a poor rooting and sucking reflex, they're going to be a poor feeder. They're not going to be able to have good suck, swallow, breathe synchrony. They don't get good tight lip closure on the nipple. They're not going to be able to use their tongue to lateralize food in order to eat. A strong AT&R limits reaching out of exploring textures and shape. If the child, every time they move their head, their arms have to go in position, it's not going to make them very functional. Another example is a persistent tonic labyrinthine reflex. If it's delayed, it's going to limit sitting. And a persistent ST&R will limit crawling. If you're unfamiliar with these particular reflexes, I suggest you go back to your OPAL class and review. Okay? Late neck and body righting reactions are going to make it challenging for the child to roll over, sit, crawl, stand, and walk. And continued primitive reflexes may impact the parent's ability to perform child care activity. Remember that reflexes are involuntary motor responses to a particular sensory input and are designed to help with survival. And when a child is unable to progress to patterns of voluntary controlled movement, a motor dysfunction is going to be observed. A reflex becomes pathological when it occurs with greater persistence and when the child cannot willfully move out of stereotypical patterns of movement. And for example, if the child has an AT&R, if every time you turn the head to one side and you get flexion of the upper extremity on the skull side and extension of the upper extremity on the face side, if that happens every single time the child's head turns, it's considered obligatory. And when it's obligatory, that means that it has to happen every time you move head position. That is a very strong indicator that the child is not going to develop functional, voluntary controlled movements. We're now going to take a look at some of the postural reflexes that are abnormal, apply some of the principles we just learned about. This first picture is a child exhibits a persistent rooting reflex. The rooting reflex, the onset is usually at 28 weeks gestation, and it should be integrated by 3 months of age. This child is obviously older than she is exhibiting the response. Okay, this child's face has been gently stroked on the side by the lips to the cheek, and she is responding with a tongue lateralization of the tongue, maybe a little bit, or orienting towards us. Because she is older than 3 months of age, the persistence of this reflex, it may interfere with her eating, her sucking, and later managing oral foods with her tongue lateralization. This is a picture of an abnormal symmetrical tonic neck reflex. In normal development, the emergence of the STNR comes in around 4 to 6 months of age, and it's usually integrated by 8 to 12 months. You can see this child has forward head flexion, upper extremity flexion, and lower extremity extension. The functional significance of this persistent reflex is that the child is not going to be able to crawl as long as he has this reflex. This is a positive supporting reaction, and I'm not sure you had this one or not. I put it in here because it's very common in children with spastic diplegia. You can see he's up on his toes. A positive reaction is normal from 3 to 8 months of age, and anything persistent after 8 months of age is an indication of a delay in development. I think this demonstrates a strong extensor tone in the lower extremities when any weight is placed on the bottom of the feet. Obviously, it's going to interfere with the child's ability to walk. The picture of the child on the left side is the reflex that's being demonstrated is a tonic labyrinthine in prone. The position in typical development, with the child in prone, and just watch what they do, and the response would be there would be no increase in tone. But this child has, you can see tone all the way through his body, extensor tone. He can't separate, it doesn't have any head riding. His shoulders are elevated and his head's resting in hyperextension on his shoulders. That's the only way he's able to lift it up the body. He's compensating for his lack of voluntary motor control. You can see that his shoulders are in extension, back is in extension, hips all the way down. Okay. The child on the right is exhibiting a startle / Moro response. The onset of the Moro is usually between 28 weeks, is at 28 weeks gestation, and is usually integrated by 5 to 6 months of age. You hold the child in support in supine and use a vestibular response of letting go of the head slightly. You get this response of shoulder abduction, the upper extremity extension. After that initial response, they'll come into flexion. You can also elicit the response through a startle reaction, and that's what this picture is demonstrating. So children who motor a movement dysfunction, pretty significant. You can see that the response is being set off by the shaking of the maraca, which isn't a real sharp sound. The children who have this persistent startle reflex, it's going to interfere with any aspect of function. Although the eyes are covered up, this is for security reasons and not that the vision is occluded. This is actually the reaction that they're trying to elicit is one of optical riding. Optical riding begins at birth and is usually should be present anywhere between birth and 2 months of age. It's integrated, it should persist through life. So when the child's body is tipped to the side, they should react by riding their head in alignment with their body. And obviously this child is much older than 2 months of age, and she is unable to orient her head to the vertical position. Lack of head control is going to get difficult for her to sit up, to feed herself, to play. Probably think of any functional application that this would be a problem. This is a picture of they're attempting to elicit a Landau reflex. A Landau, the onset usually comes in around 3 or 4 months of age, and it is integrated by 12 to 24 months. The testing position is position the child in prone, supported in air, and you wait for a reaction to. You can either actively or passively extend the head, and the reaction that you're supposed to get is the hip back, and then the hips will extend in a sequence, so it gives the child a Superman appearance. The functional significance is that it breaks up total flexion patterns seen after birth. This child does not have the reaction, and it is going to significantly impact his ability to maintain an upright position, to hold his head up, to sit up, and for any functional task. This is a picture of a child that is demonstrating an STNR reaction in supine position. You can see she's holding an object in her right hand, probably attempting to move, to roll over. And when her head is flexed, her upper extremities are flexed, and her lower extremities are extended. So she is totally dominated by her reflex activity, very minimal volume. And the final picture is a child demonstrating an asymmetrical tonic neck reflex. Her head is turned towards the left, so her skull side is complete flexion on both upper and lower extremity, and face side she's exhibiting extension of her arm and leg. This concludes the lecture for the movement dysfunction module. If you have any questions about any of these concepts or the pictures and trying to understand what's going on, please see me and I'll be happy to further explain. All right, thank you for your attention.